Now,
Okay.
Karen, if you want to get started as she gets going, that is at your discretion.
I'm fine with us getting started. I just wanted to welcome our board members to our first virtual board meeting, and apologize for the delay, but with the COVID experience happening, it caused us to be a few months behind, and so our sincere apologies for that. But we are very excited to have you here with us today, and we have a robust agenda for you. A lot to do, to accomplish this time, and so we are very grateful for your participation here today. And Beth, I was just going to check at this point, are we going to do the roll call now, or?
Yeah, the roll call will be fine right now.
Oh, okay.
Just to see who's there, so we make sure we have our quorum. That's fine.
That would be great. So do I do the roll call then?
You can.
Oh, Beth is, I think, right?
Oh, that's right.
Okay.
Just a moment. We're working on a small technical challenge here. Bear with me for just a moment.
Okay.
I believe that may be one of the most common phrases used these days.
It's quite a bit of it.
And if not, it serves as a convenient excuse, for me at least. That's the old equivalent of talking on the phone and crinkling up paper saying, I'm losing your signal.
Yeah, it's interesting. There was a video that went around on YouTube of this gentleman was making fun of yes, and he used his labs to be the virtual partners, and one was, of course, a very well-behaved dog, and the other one not so much, and it lended into like the various personalities and behaviors of people too on the call. It was quite hilarious.
Oh, I have to try that. Get my dog out here.
I'll have to see if I can track it down, and if you all are curious about it, it really was funny. Cute. We actually shared it, and I'll speak to some of the ways we communicate with our staff on a regular basis, and as a lighthearted gesture. I mean, we could probably send you that weekly update, but it had the feature of the little dogs in it, just to provide some fun for people.
All right, I do apologize. While we're still working out the slides, I'm going to go ahead and do the roll call. As I do the roll call, would you please shout out and let us know that you're here, please? And I do apologize. Some of the names I do not want to mess up, but the first is Mr. Peter Kongsveld.
Close. Kongstebet.
Thank you.
Just like it's spelled.
Okay. And Dr. Ali Razudin. Dr. Ali, are you with us?
Yeah, you may have to unmute.
There he is. He just joined us. I saw him, so to speak.
Yes, he just texted in. He's present.
Okay.
He may be having problems with his mic. I don't know.
Okay. Next would be Dr. Cook, Dr. Patricia Cook. Okay, Dr. Cook may not be with us today. Rebecca Will?
Yep, I'm here.
Okay. Dr. Cameron Webb? May not be with us today. Greg Peters?
I'm here.
Thank you, Greg. Michael Cook?
I'm here.
Thank you. Maureen Hollowell?
Hello.
Alexis Edwards? Alexis may not be with us here today. And I'd like to introduce the DMAS Executive Leadership Team, as we've already heard from, and that would be Director Karen Kinsey, Chief Deputy Ellen Mons,
Good morning, everyone.
Chief of Staff Ivory Banks,
Good morning, everybody.
Deputy Director of Complex Care Services Tammy Whitlock,
Good morning, everyone.
Deputy Director of Programs Cheryl Roberts,
Hi, this is Adrian Fagan sitting in for Cheryl Roberts.
Deputy Director of Administration Rachel Pryor,
Good morning, everyone.
our Chief Financial Officer Kris Gordon,
Good morning, folks.
and finally our Chief Medical Officer Dr. Cheetham Bhakarati.
Yep, Chetan Bhattacharya. Thanks, Beth. Appreciate it. Good morning, everybody, and thanks for your time and attention this morning.
We'd like to ask,
Hey, but this is Kannon. I'm present too.
oh, thank you so very much.
No problem. Thank you.
I do want to remind everybody at this time, sorry I didn't mention at the beginning, but this session is being recorded. Are there any other members of the DMAS staff that would like to introduce themselves at this time?
It'd be helpful for the team who works with the board to recognize themselves.
Craig Markfa, Director of Communication Legislation Administration. And Brooke Barlow. You going to introduce yourself, Brooke?
Brooke Barlow, I'm the DMAS Board Secretary. And Nancy Molchewski, Public Information.
That's all of us.
Okay, that sounds good. Okay, I believe we've done the roll call.
And finally, we want to ask if there are members of the public that would like to make themselves known at this time. All right. And I would like to ask if anyone is able to see the presentation on the screen.
Yes, can see it.
Okay, wonderful. And I would like to turn it over at this time to Dr. Karen Kinsey.
Okay. Well,
Doctor, I'm so sorry.
No, it's fine. It's fine. Hi, everyone. How are you? It's great to see everybody this morning. And I see some of you are participating visually, so that's great. Many of our staff, and I'll talk about this a little bit, when we shifted virtually, not everyone has a video capacity at this point in time. So that's why you're not necessarily seeing folks on the screen. And so we're a work in progress on that piece at this time. And so I just wanted to thank you all for your attendance and participation this morning. It means so much to us to have you here today, and also to our participants on the line who are here as part of the public to be a part of our public meeting. So we're grateful to have you here today. And the first thing I think we're going to talk about on our agenda is the approval of the minutes. And so I know that the draft minutes were sent out to the board members. Does anybody have any additional comments or suggestions to it before we have a motion to approve? Okay. Do I hear a motion to approve the meeting minutes?
So moved.
Okay, thank you. Do I have a second?
Second.
Thank you. We have approved the meeting minutes. Yes, Brooke?
Who was that seconded?
That was Kannon Srinivasan.
Michael Cook and Michael Cook.
And Michael
So
Cook.
whatever.
Thank you.
First and second, we're good.
All right, thank you.
We have a host of volunteers for that, so that's great. Thank you. All right. Moving on to our next agenda item. We want to recognize a very, very special guest with us, and it's Dr. Karen Rubin on the line. Dr. Rubin, are you participating with us? Well, can we scroll down to, actually, I know that she's going to be online with us. Craig, doesn't she indicate she'll be coming and joining us?
Yes, yes, she may, there just may be some, she may have some technical issues. I don't see her name currently
Okay.
listed on the, there, but she will be joining us, yes.
Well, if the members of the board are comfortable with this approach, I'd like to skip this, the recognition for Dr. Rubin right now, and we'll wait till she comes back online, and then we can do the recognition for her when she's able to join us.
Sure.
Okay. Thank you so much. All right, so team, we will wait for that. And then what we'll do next on the agenda item is move into the election of officers. And before I start this, I do also want to recognize there's a member from our Office of the Attorney General. Is there somebody from the AG's office present with us today? I just wanted to recognize you. Okay, perhaps we don't have somebody attending on that either, but that's okay. Just wanted to double check. So the next on our agenda is the election of the board officers. And we have, with Dr. Rubin leaving the board as she completed her term, we have an opening now for nominations. We have openings for nominations for chair, vice chair, and the secretary being open at this time. And so, Beth, I will turn it over to you to do the nomination process. Beth, are you on?
Yes, I am. At this time, would members of the board like to make a nomination for the first opening for chairman?
Yeah, this is Kannon. I would like to nominate Michael Cook for the chair.
Are there any other nominations?
Maureen, you're on mute.
This is Maureen Hollowell, and I'd like to second the nomination for Michael Cook to be president of the board.
There has been a second. So Michael Cook has been nominated. Is there any other nominations at this time?
Okay, well, if there are no additional nominations, then it is a default to unanimous vote, and that Mr. Cook, you are now our board chair.
Thank you.
Congratulations, and it's an honor to have you as our chairman leader.
I look forward to working with everyone, and very much appreciated.
Well, we've had the distinct pleasure of working with you for some years now, and you have always been a very strong and passionate leader for the Medicaid program and the changes that we make on behalf of our members and the providers who support them. So we appreciate your leadership at this time.
Thanks.
Okay, Beth, would you like to move on to the other nominations?
Yes, I believe the next nomination would be for secretary.
For vice chair, I believe.
Oh, for vice chair. My apologies. For vice chair.
I would like to nominate Kannon.
Could you tell me the full name, please, for the record?
Yeah, sorry. Kannon Stribus. I'm sorry. I know with a name like mine, you'd think I'd get this better.
That's okay. I got it.
Srinivasan.
Yes.
Thank you, Peter.
Do we have a second?
I'll second Michael Cook.
Okay. So the nomination has been made and seconded. Is there another nomination? So at this time, there is only one nomination for vice chair.
That is correct. No
Okay.
other nominations.
So does, Karen, do you want to do an actual vote or just a proclamation?
I think it's a proclamation because
Yeah.
it's not unanimous, so it's automatic. So congratulations, and we are very excited to work with you, Kannon, on your new role in vice chair.
Thank you. Thank you so much. It's an
And I
honor to be involved and say thank you.
Yeah, thank you. Yes, and we've also been working with you for some time as well, and we appreciate your willingness to step up in a leadership role with us.
Thank you.
And I apologize, I have to step out for 1 second. My computer's acting up, so it'll be only a minute and I'll be back in. Keep going, please, with the nominations.
All right, and now we get to the nomination that I tried to jump ahead on, which is for the secretary position. Do we have a nomination?
Brooke Barlow.
Do we have a second for Ms. Brooke Barlow?
Second.
Okay, there's been a nomination. It's been seconded for Brooke Barlow for secretary. Is there another nomination?
Okay.
I don't think you're safe.
There being no other nominations, it was just seconded?
Yes, it was seconded.
Yes.
Oh. All right, so if there are no nominations, I guess by proclamation, Brooke Barlow, you are now the continuing secretary.
Thank you all.
And thank you, Brooke. You do a wonderful job of being a secretary chair. So we appreciate everything that you do.
I'm standing over her right now. I'm ensuring that she would say yes, so that's great.
I'm sure it's social distancing, Craig.
Oh, of course. Wearing a mask and everything.
Okay.
Well, want to thank you all for your attention during now. As soon as Karen gets back on, we will proceed with the presentations.
And we've just concluded the election of officers, so yes. Okay. Has Dr. Rubin joined us by any chance? Okay.
I have contacted her by phone. She should be on in a few minutes. If she's not on yet, she will be joining us. I have confirmed that.
Oh, great. That's excellent. I'm excited about that. So trying to say if it's going to be a few minutes, I maybe should just do my report real quick and then we can catch Dr. Rubin at the very end, if that would be amenable. Just
Sure.
Michael,
Yep.
this is
Sure.
Maureen. I'd like to say something, please.
Sure.
I think that I'm not sure exactly of the content of Dr. Rubin's of how this is going to move forward, but I would just like to remark that I think it's appropriate that we're having this meeting by electronic means, considering her lifelong work professionally with telehealth.
That's an excellent point, Maureen. Thanks for pointing it out. Excellent point. Thank you.
Amen. Amen.
I agree with that completely. Well, Michael, what would be your preference as the chair, to remain a few minutes or
I think we should proceed, and then when Dr. Rubin comes on, we can move forward.
Okay, and Craig, if you could just let us know, we're happy to pause at that moment if it would be of assistance to Dr. Rubin as well. Okay, so as you see, we have a full agenda. We've been moving on it already, and now we have the opportunities to provide you, and you can scroll down, please, past that slide. Here we go. Scrolling up on this to talk to you a little bit about what's been happening with the agency particularly, and I'm going to be providing my report to you about all the activities being done related to Medicaid as it pertains to COVID, and then the rest of the team will provide you with a lot more detail about nuances about exactly what we've done with our flexibilities to better support our members as well as our providers who take wonderful care of them. And in order to do that, we had to first make sure that we're taking care of our team. And I did want to recognize that I'm so proud of our team and stepping forward in the midst of this crisis, this health pandemic, of which people had their own concerns and worries and their own families to take care of. And in the middle of all this, we did not skip a beat in terms of supporting our members and the providers. And so just wanted to give a huge shout out to the team for all that effort. So just for you all to know, we were prepared for many types of situations. We had a continuity of operations plan. We call it our COOP. But one thing that really was not mentioned as securely, and there was a pandemic. And so everyone was moving swiftly to think about what do we need to do? How do we need to properly plan? We actually started shifting the executive leadership team and critical staff to do coordinated planning for the remote working work that we thought we were going to have to do as early as the first full weeks of March. And this involved us updating our teleworking policy. So a nod to Dr. Rubin for some of this work as well. Absolutely. What flexibilities did we need? What types of equipment did we have? Over 700 individuals working in the agency, full-time, part-time, as well as our contractors. And so we need to make sure that we were ready to shift and be nimble for our agency. And the existing telework policies that we had in place had to be reviewed and updated to give us those flexibilities. And we all transitioned. So thank goodness for some of the hard planning work that was done up front. We had about 24 hours to transition into remote teleworking on March 18th. And everyone shifted within one day, over 700 people. And we did, as I said before, everyone stayed focused and determined. We did not miss a beat even when we moved. And so there was a smaller location that we had to set up for our COOP location with a health department, Richmond City Health Department, because there's some tasks that can't be completed remotely, such as the incoming and outgoing mail, which we still receive quite a bit of for you all. Maybe we're not aware of that. But there was a lot to do to go into that, and with appeals processing and a few other pieces that still had to be done. So we have an offsite location of which our one of our deputies, Kris Gordon, gleefully stays there and helps us out with managing that day-to-day work. So if you can move to the next slide, please. So we shifted and we kept the work up. If anything, the work increased significantly for the teams. And so we were working very hard. As you can imagine, while people were shifting from this environment into another, and I believe, hang on, this might be Dr. Rubin. Is this Karen?
No, that.
Oh, okay.
Karen, are you with us?
I thought I saw somebody named Karen asking to submit it. That's
oh, that may have happened.
It was her, but she's muted.
Oh, she's on mute?
She's available now. Dr. Rubin?
Okay, maybe it was a different Karen.
Yeah, I don't see her. I believe it's a different Karen.
All right, my apologies, everyone. I'll keep moving on the discussion. So our focus at this time has been, as people work and they've become isolated in their homes and communities and they're with their families, and you have the increasing stressors of, family life and supporting your loved ones, human or furry, because some of us, animals, our pets do keep us hopping at home too. But how do we best, we talked about as leaders, support our team as they migrated into this telehealth environment, working environment. And so there's some additional flexibilities we have done, acknowledging that people had kids at home and possibly elderly loved ones staying with them. We allowed for flexible working hours to help accommodate that. Some families were taking like early shifts and late shifts so they could, help take care of others, but still meet their work obligations. And we've also engaged with our staff often and as frequently as we could. For example, our chief of staff is Ivory Banks. Their office created a virtual community blog for our teams to be able to stay connected as you telework at home, forming categories including working from home, how people stay well, creating joy in their lives, and also how we stay connected, because that's the big piece for us, is continuing to stay connected and make sure that we take good care of ourselves, but also that if we do that for ourselves, then we're able to be present and do strong, great work for our members and our providers. And so some other things that we've done to help people with better manage this situation, which is quite stressful at times, is mindful movements. So we 2 days a week, we do short virtual meditations offerings for people so they can get together and help with them with better managing the stresses of everyday and then COVID environments, as well as our work. We've also just recently done virtual yoga offering to help people, because that we were doing it before in the agency and people loved it, and then we shifted, and so now we're offering that virtually for our staff. We are also very mindful because we did a survey as soon as they went out. We said, what's important to you? What is something that's concerning for you? What do you miss? How can we help you? And people were saying we miss leadership training opportunities. And so we've picked that back up, and we're doing virtual supervisor and manager trainings right now, ongoing. Also, our big focus is on how do we keep our staff morale up and, running strong during this time, and let people know how important they are to us and how much we value what they do. So we're continuing. We have awards that recognize the values that we have here in the agency. And every year at our spring meetings, we acknowledge people with the Living the Values Award. And so the 5 values of service, collaboration, trust, adaptability, and problem solving, we went ahead and did that as well to honor people who did that, who were recognized for that. We're also doing shout outs during the month of May. The directors recognize somebody or a group of people who are doing wonderful things in the agency at that time. So we're working very hard to do that. Another thing that's been critically important, we've discovered too, is regular communication with them to make sure that people know what's going on and any impacts not only within our agency, but within the state and possibly nationally that we talk about, especially within the last couple of weeks. And so we do daily staff communications, which provides critical human resources information and anything else, especially as we move to transition back into the building. What does that look like? How is that going to feel? And I also do what's called a weekly update from my porch, where I just sit and do various things and updates for people. And so we do our very best to stay as connected as we can to them. And I will pause, if you all have questions, please don't hesitate to ask at any time.
I'd like to point out that Karen is in with us now.
She is?
Yes.
Oh, okay. Well, Michael, what would you like to do?
I think, why don't we do the award for Karen and then get back to questions and the presentations.
That sounds great. Dr. Rubin, you're on the line. You may be on mute. Oh, it says it's not unmuting her. Can somebody go in and unmute the person who is named Karen, please? I just saw a note. It's okay, Karen. It's not your fault. I think it automatically mutes people once they come on after a certain number of folks. So it's all good.
Karen, are you there?
It's not opening her up on this end, unfortunately. It may be something at your end, Karen.
Karen Kimsey.
Yes, sir.
Should we simply we can either proceed with the award, unfortunately without Karen being able to respond, or we can move forward with questions. Probably better to move forward with the award, if that's all right.
Okay.
One last thing, if I can interrupt, and I do apologize, but I want to let her know that if she's using her phone, *6 will unmute her phone. That's not it. Oh.
Okay.
It's through the computer.
Michael, I'm happy to read and do the acknowledgement for Dr. Rubin, and when she's able to join and talk, she can let us know.
And we can see Karen, we just can't hear her.
Yeah.
Karen, Karen Rubin, can you text us in chat as to which would be your preference, whether you want us to finish Karen Kimsey's director's report and then move to the award, or whether you want to go forward with the award now, if you just text. And in the chat box.
Okay.
Okay, great. Karen Kimsey, do you want to finish
Yes,
your
sir.
report then?
Yes, I'm happy to move forward. Okay, so the next piece is what we're talking about right now is how we're shifting back into the next slide, please, Valerie. Thank you. Back into the building. And as I mentioned earlier, we did the survey, and the survey is very important. How we transition back to the building is critical. And so first and foremost for us, the health and safety of our staff will always remain our priority. And as our former director used to say, Cindy Jones used to say, first do no harm. And so that is always something that we will have foremost in our minds, and is so important to people that we did a survey, as I mentioned earlier, and we had, remember, we had 700 people in the building. Over 400 people have responded to the survey and expressed their concerns and questions and comments related to how we move back. So we also just finished some listening sessions. So we posted our draft transition plan and also the steps that we're going to take within the building to help keep people safe as we move back in. And we had over 300 people participate in those listening sessions as well. And we got to hear their thoughts and comments as well. So for the leadership itself, just on the survey highlights and partial, also with the listening sessions, over 83% of those who did the survey do believe that the agency leadership is taking their comments and thoughts into account and very seriously. So we felt very good about that, knowing that people are feeling heard and that their comments are being taken into account. Overwhelming majority of them are just primarily concerned, about 83%, with actually contracting the virus, or that there are safety issues that may come into play that may put them at risk with contracting the virus itself. And so 1 in 3 of our staff are very worried about moving back into the office in a timely manner. And the majority actually do, as a result of this experience, feel more positively as well about teleworking, that the agency itself was actually able to function very well on a teleworking situation. And so it's also going to cause us to take a step back and take another look at how we function as an agency in the future and what individuals could remain teleworking, or roles and functions versus individuals coming back into the building. So part of that is phasing in and we're looking at it from a business need, business process standpoint. What actual processes have to return back into the building in order to function well? Like one, for example, that we're looking at is appeals. That's a pretty critical component for us right now, still primarily paper-driven process. And so that's one area that may likely need to move back in first, just as a point of example for you. Also, staff are very concerned about ensuring that we have proper PPE and that people exercise proper social distancing, of which we'll be setting up the building and the offices to reflect that, and the meeting spaces will likely still be using these virtual meetings, even with people being in the office. And we've already ordered and have ready and waiting for each person proper gloves, masks, enough to last them for several months. So we'll be providing that, hand sanitizer. The building will be cleaned twice a day, as a matter of fact. And so we've been working very hard to make sure that we'll be ready and in place. So our plan also aligns with the governor's phased-in process, and the lion's share of all the individuals who will be shifting back into the agency will likely do so in phase 3 of the governor's phased-in process for the Commonwealth, returning back. So we have 4 phases in total. They spread about 3 weeks at a period, so it gives us time when the first group moves in to adjust and flex as we need to before we move other staff back into the building. And of course, at any time, should another bloom hit or wave hit and we need to shift back to teleworking, we'll be able to do so in a nimble fashion. And so also recognizing, Michael, you had mentioned this earlier, with people, if possible, if they test positive, there are proper protocols in place related to that. If somebody were to test, who we notify, people to go home, and then how they, shelter at home until they get through either diagnosis, or if people are exposed, then they go home while they wait to see if they have the symptoms. And so that is in accordance too with the building policy. We have 2 other renters in the building with us. So just for you all, you may not be aware, we are not in a public building. We are in a privately owned building that we rent. And so it's a little more complicated for us than it is for the state building. And so each time if somebody were to test positive, we'll have to literally shut that part of the building down to be cleaned, and people will have to telework for several days. So there are strong measures in place. We're coordinating with the other 2 tenants. They will be following similar protocols. And so we feel very comfortable of where our plan is at this time. And Ivory Banks, who is also leading this charge with us, our chief of staff, is also available if there are questions that you may have with this that she can also help answer. Okay. Hearing. Oh, yes.
Karen, yeah, can we ask the board, does anyone have questions at this point in time? Okay. I have a question, Karen. Contact tracing, do they have we implemented a program in that area?
We do. We have a mechanism in place if somebody were to test and contact tracing, but we part of our process is deferring to the health department. So the health department actually has hired staff, hundreds of staff to handle contact tracing. And so when a situation happens here, we reach out to the local health department of which it's been impacted, which is Richmond City, and then file a report and handle it from there.
Thank you. It sounds like you've done a fantastic job here.
Well, credit to the team for doing that. Is just you're right, it's a significant undertaking, but it if it had to happen, it went as smoothly as possible. So thank you. Okay, well, Valerie, we'll move on to the next part of if there are no additional questions.
Karen, this is Greg Peters. I wondered if I might just briefly introduce myself, since this is my first meeting. That's all right, Dr. Cook. That's fine. I just I know I'm seeing new faces, but just that I don't know, Karen, if you would like to do that, or just I'd be glad.
Actually,
I just wanted to acknowledge that I was a new member to the group and just learning on my first time.
Yes, sir. My sincerest apologies. I do have you on the list to introduce you, and we are very, very pleased to have Greg Peters join us. And I've known Greg for many years in his capacity with United Methodist Family Services and his leadership role there. And I will turn it to you, Greg, to talk a little bit about your background. But just for folks to know, we have worked with Greg for many years in the Medicaid program and the work that they do in supporting children, providing support services to children who have behavioral health needs and other needs. And they have been a wonderful provider, partner, and also not afraid to talk to us when there are serious issues at play. And but a very strong partner and believer in the Medicaid program as well, and how it supports individuals. And we're very pleased to have Greg join us as a board member, and look forward to your leadership with us as well on the board. And Greg, would you like just to give a little bit more background about yourself?
Just real quickly, and I apologize for coming in your report, but I thought you might wonder who the stranger was up in the corner that you're talking to, Dr. Cook. I appreciate Karen and I have had a long relationship, and Cindy Jones many years ago, I guess I was on, my first contact was DMAS, was when we had the residential treatment centers and treatment foster care become part of the DMAS program. And so I've been involved for many years. I'm an LCSW, and I've been the CEO of UMFS for 20 years. I've been at the organization for 40 years, and we're celebrating our 120th year this year. And we had not planned to celebrate it with COVID virus, so it's been different than we anticipated. And just real quickly, as Karen said, my interest, a lot of the children and families we serve are on Medicaid, but where we really have worked a lot is in behavioral health with children's services. And we do that with residential treatment. We do that with crisis stabilization. We do that with intensive case coordination. We do that with treatment foster care program. we've also created a lot of initiatives with the state, and Karen's aware of one of the most recent ones we've done is a training center for high fidelity wraparound, working with DMAS and the Department of, we actually are Department of Behavioral Health, we're a partner. And also we're with Project Life with the State Department of Social Services, where we're working with all of the children that age out of foster care. And we have been training throughout the state. So a lot of what we're doing are programs, but also best practices. I appreciate just the final thing I'd like to say is where I got to know Karen and Cindy Jones very well is I was a member and appointed by the last 5 governors for the State Executive Council of the Children's Services Act. So I know DMAS does a lot with the Children's Services Act, and that's where I had been involved as a private provider for many years and made many of those contacts with commissioners and others throughout the state. So I welcome the opportunity to get to know y'all and learn more, continue to learn more about DMAS. But as Karen says, we work on a very frequent basis with many initiatives. So thank you for letting me join your group.
Greg, welcome. And just on a personal note, I'm on a board of a charity that partners with universities and colleges to prepare hard to place foster kids for college and post high school life. So it's a welcome, and it's great to have you on board.
Michael, I'd love to talk to you about that further, because that's an area that we're working with a lot with some of the local programs around the state. So yeah,
offline, that'd be great, Greg.
That'd be great.
And we do welcome you, Greg, and agree that you bring a very balanced approach for our board, and your perspectives will be warmly appreciated here.
Thanks, Karen.
Absolutely. And my sincere apologies for not doing it in front of you.
No apology needed.
I will openly admit it's an adjustment. I miss seeing your faces. If you were sitting around a table, I would have seen you immediately and just
it's hard.
So navigating this world we have now. Okay.
Sure.
So let's
Karen, do you want to continue?
Yes, sir. Happy to do that. So we'll move on to the next slide. So as we look at this, the value of Medicaid itself during COVID-19, and so even our own president acknowledged that Medicaid and Medicare will serve as a safety nets to help people during this very critical time. And we wholeheartedly agree with that statement. And actually happy to hear him actually acknowledge Medicaid in that way. That our mission here, at DMAS has always been to improve the health and well-being of our members through access to high quality healthcare coverage. And so this this pandemic demonstrates more now than ever the critical importance that Medicaid plays in our lives. And we offer, the life-saving coverage to now 1 in 6 Virginians. It's grown quite a bit, including the more than 420. It's actually 426,000 newly eligible adults in the benefits. So to think about that many people may not have been without health coverage during this pandemic is, but now that they do, it's great to have that we're positioned in a way to be able to support people. So in the early days of our health emergency, we did act swiftly to develop and implement policies that strengthened access to coverage and care, working very closely with you all and other critical partners. We've also responded to our increased enrollment needs as tens of thousands of individuals, it's around 74,000 people, I think, who have lost their jobs have now turned, and health insurance have turned to Medicaid now for that coverage. So we've had that many additional people join the Medicaid program since the COVID pandemic started in the emergency period.
Suspended.
And Rachel is going to go into a lot more detail, but Medicaid also serves as a safety net, not just for people joining us, but for people who are currently on it. And she'll spend a more detail talking about that with you. And over the last 3 months, just all these initiatives that we've done to help support our members and our providers, we're going to spend more detail talking about that with you, and then where our next steps are going forward. So essentially, we've got our members covered. We have the access to the coverage, that we have access to the health care that they need. As you can see on the slide bullets here, we did a variety of things to make sure people were just, if they need health coverage, if they need to see a doctor or go get treatment or get tested, They can just do it. They don't have to worry about a copay. They don't have to worry about pre-approvals for certain services. If they have medications and they need it, they don't have to wait for most medications. Then they could just get a 90-day supply, not have to worry about going to the pharmacy, that it could be delivered to them and provided to them. And of paramount assistance has been the telehealth approach, which has really, really helped people to stay connected to their practitioners, to get necessary mental health services and supports, which are critical at this time, as well as addiction and treatment. So also, it's a critical issue for us in terms of health equity. And, you know, so in over our 50-year history itself, we have proudly served as a health agent for this particular piece, because many of our members are vulnerable and at risk already. And so providing coverage and access to quality care for these populations who have historically faced barriers when seeking care is critical importance to us. COVID has also brought many of these inequities to light, as you all are well aware. And so we are pursuing improvements in health equity through innovations, particularly maternal child health coverage and behavioral health, as we cover nearly 40% of births now in the Commonwealth. And so we also are a critical safety net for older adults, including 60% of our nursing center population and the residents who have particularly been at risk and for COVID and have really suffered quite a bit through that. And our providers in the nursing centers have worked so very hard to take care of the members as they can. So that's a very high risk population we're paying particular attention to as well as with people with substance use disorders. You probably may know that we have seen increases in overdoses during this time due to people, you know, going to drugs to help manage the stresses that they're experiencing at this time. So having treatment available for people is more important now than ever. Okay, the next slide, please. We also though want to make sure people know that we have our health providers covered. That not only are we want to take care of our members well, we also want to support our providers in the best way that we can. Some of the flexibilities that we have already done to date right now, you'll see on the slide, include provider retainer payments for adult day health centers, and as well, and it says providers that offer day services. For those of you who may not be as familiar with it, these are services offered through the DD waiver systems. And so this includes group day, community engagement, and community coaching. So what we're doing right now is paying a percentage of what their rate would have been to them to make sure that they help stay afloat, because these providers have literally had to close their doors during this time, and CMS has approved it. So all these flexibilities we've received approval for CMS, and also approval at the state level to cover. We also, in recognition of the additional needs related to our nursing homes and centers, also called facilities, have increased their reimbursement rates by an additional $20 a day because of their high risk. And we're also continuing to work with them and a special work group across the Commonwealth to identify needs for them to better address COVID during this time. Also, we're continuing to work closely with other providers in our network to identify what their unique needs and costs are related to this time. And we've also had some submissions for consideration by the administration at this time for CARES Act funding to help keep some of these providers afloat. And if you also did not see yesterday, HHS is announcing that they will be providing additional dollars to those Medicaid only providers who have not seen relief yet through any of the Stimulus Act funding. So we are very anxious to see that come to help support our providers. And then also when we see that, it also helps us to inform how we move forward with CARES Act funding to better support them, because we need to keep our network in place during this time. And because as we've had more members join us, our network is critical now more than ever.
Karen, and I apologize for jumping in real quickly here, but one of the problems the providers have had with in the past with some of the CARES Act funding is that they don't get, that they're thoroughly confused about the certifications for it. So can the department help them clarify some of the confusion out there if they run into it?
Yes, we're working very closely on those issues, and we can talk a little bit more about that too. Also wanting to just also acknowledge some staffing flexibilities for some providers to give them more flexibility with hiring people and with the training and oversight and some of the other requirements that are in place, as were mentioned, and also for consumer direction, in particular personal care. We're allowing spouses and parents of minor children and legal guardians to be paid down, to be caregivers during this very critical time. Okay, next slide. Also, as you are likely aware, we are facing a significant budget shortfall within the Commonwealth during this fiscal year alone, estimated to be around $1 billion, and an additional $1 to $2 more billion starting next fiscal year, which is July 1. And so we are working very closely with CMS and our administration to receive the additional federal dollars that have been provided to Medicaid programs, and also through emergency waivers. I've mentioned to you some of the flexibilities we're providing with our providers themselves to help reduce the strain not only on our state budget, but also to help our providers along as well during this time. And we're very committed to making sure these funds are used in it to address the COVID experience itself, and hopefully helping those individuals who are at highest risk. Okay, next slide. So the next coming months in terms of looking at how we demonstrate to people, so we really want to show people how Medicaid has been helpful in supporting people during this time. So we're going to be coming up with targeted communications to highlight the value of the program itself across many program areas. The first we did was actually take a look at our website and structure it to make it a little more user-friendly. And we even set up a COVID page, web pages for providers as well as individuals just seeking information to try and help them have as much information as possible to stay as informed as they can. We're also going to be looking at developing value measures and communicating these to stakeholders for exactly how. For example, looking at telehealth as a measure, how many providers utilize that or individuals did, and also highlights the valuable accomplishments through the Medicaid, but also for future goals that we're working on to demonstrate the value of this very critical program on behalf of the Commonwealth. Next slide. And I just want to show you a quick little video when we reached 400,000 individuals, you know, and we were so excited about it, but we were right in the middle of the experience. And so the team at the agency created this little video that we'd like to share with you right now. We can't hear the video. Also, to let folks know, this was videotaped by ourselves in our homes, so it's organic. I'll put it that way. Valerie, are you unmuted?
All right, Valerie is going to see if she can pull it up directly from the YouTube video.
Hi, Beth. I think Valerie needs to unmute herself.
I'm unmuted now.
Okay.
Sorry about that.
Thanks, Valerie.
I got carried away.
Okay, well, if it's not able to come up in the next minute or so because we have so much going on, we can always, if time allows, come back if it doesn't work this time.
Can you hear it now?
Yeah.
Okay. These individuals have critical access to health.
Okay, so this isn't working. What we can do is, for some reason it's gone on, we can't hear it. And so what we'll do is we will make sure that you receive a copy of this, and we'll send it to you electronically so you can view it if that's agreeable.
That's perfect. That's great, Karen.
Okay, well, thank you so much, and my apologies for we're having some glitches in terms of our being able to share use these technologies at this point in time, but. Okay, so at this point, I conclude my director's report. If there are any questions people may have, I'm happy to entertain them, and otherwise we can move on with other updates for you.
Does anyone have questions? Karen, I think moving on would be a good idea then.
Yes, sir. Oh, we can also hear the speaker point for Dr. Rubin.
Yes, she is online audio through her phone. So, Dr. Rubin?
Can you hear me?
Yes.
Say yes, yay. Let me just say, everybody, first of all, as the director of the Center for Telehealth at UVA, the fact that I couldn't get my computer microphone to work when it's been working for Zoom and WebEx and WebRTC is really embarrassing. So anyway, thank you for allowing me to join this morning.
Oh, it's our distinct pleasure to have you with us today, Dr. Rubin. And we just wanted to, we had shown the board members a picture of your award just a few minutes ago. But what we wanted to do today is just thank you so much for coming on board today. We just couldn't let this opportunity go without thanking you for everything you have done over the last 8 years for us. So Dr. Rubin has been on our board for 8 years now and serving 6 as our board chair. And your leadership for us has been so meaningful. And so you, and I just actually led through just a few things, if I may, that through your leadership helped us move through in terms of improving and growing the Medicaid program to where it is right now. So telehealth, I'm just going to openly say that that's like big, and you were helping us even in baby steps moving into telehealth. And then, but once we shifted into COVID and it just all opened up, I think we were in a much more comfortable space too for that because of you and because of your leadership and work in that area. So we're so profoundly grateful to you for that. Also, there were so many initiatives that Dr. Rubin helped bring us up the last several years. And I'll just list a few off. We ended up doing ARTS, our addiction and treatment benefit, under her leadership. We developed the GAP program, our Commonwealth Coordinated Care, Commonwealth Coordinated Care Plus programs we've created under her leadership. Medallion 4 was reprocured. Like our entire system from 1.5 million individuals was reprocured under her leadership, as well as critical systems pieces for our Medicaid enterprise solution under her leadership. And most importantly, we've done expansion under Dr. Rubin's leadership and guidance and support, of which 426,000 individuals now have health coverage because of the hard work. An additional 75,000, I think, individuals who have added to our list because of COVID as well. She has been with us through 3 administrations, and that alone is wonderful in supporting us. And she has always led us, you have, Dr. Rubin, with strength and grace, and you've always been for us a fully engaged leader, one of the biggest fans for the Medicaid program, and also not only for the program itself, but for our staff as well. You've always been so supportive to us along the way. You've also given us critical advice and input on significant health policy issues as we had them moving forward. And quite simply, to close out, you've just been a joy to work with, and we have been so grateful to have you as our leader during these times. And so thank you so much for everything you have done for us. On behalf
Karen, I can't thank you all enough for the privilege of working with all of you, the board, the agency itself. Karen, you and I have been working together for many years, and as Greg referenced, you know, it's a long history of collaboration. It takes a village to serve, and each of you on this call has played a huge role in that. Greg, you're going to have a wonderful experience, and Michael, thank you for giving me the opportunity to speak this morning. And you know, I will always be here, connectivity notwithstanding. And thank you again sincerely for what this agency and this board has done for the citizens of the Commonwealth of Virginia. So huge thanks to everyone, and I might cry, so I should stop speaking right now, but thank you again.
Oh, thank you.
Truly grateful.
You may regret the statement about being there to help, Karen.
You know, we do this for one another and on behalf of our mission. So thank you again.
Well, Michael, if you're comfortable, we can move on to the next item.
Absolutely. I didn't know whether you were going to read a proclamation or exactly how you were going to.
We presented an award to Dr. Rubin, which was sent to her home, the one that you saw.
Wonderful.
And
Wonderful.
We'll have additional coming later. Yes, sir.
There it is. Thank you.
Yeah, then if we can move forward to the budget, which is obviously going to be a critical issue in coming months.
Yes, sir. And thank you again, Karen. Thank you. All right, we will turn it over to Kris. Mr. Gordon.
Thank you, Director Kimsey. As we wait for the slides to come up, I just want to briefly say thank you, Karen, for the introduction about the collaboration. The 12 slides that I'm going to step through this morning are going to speak to an overview of the Medicaid enterprise system and our financial profile year to date, which again speaks to tremendous collaboration, not only with the finance and technology team, but also throughout the agency. So next slide, please. The next slide here you see is the graphic that shows our 11 modules that comprise our Medicaid enterprise system. So quickly, for those folks that are new to the DMAS board, the Medicaid enterprise system is a replacement for our existing Medicaid management information system, so what we affectionately call MMIS. It's a legacy mainframe system that agency several years ago decided to replace with these separate modules here that address each of the items noted there, such as appeals, care management, operations, etc. As you'll note in the table below the bubbles there, several of those systems are already live. Our enterprise data warehouse that our chief deputy, Dr. Muntz, curates, as well as several others, our pharmacy benefit, etc. More are scheduled to waterfall come on later this year. But I wanted to point out and note that one of our key operational systems, our operational OPSS system, was originally scheduled to come online June 22nd. But we paused working with the vendor and we're going to have to rebase our system and come up with a new timeline effective in July. Next slide. As a result of that, it requires that we pivot to continue working with our existing MMIS system. The vendor that supports that Medicaid Management Information System, MMIS, is called Conduent. We recognized early on this spring that we would not be able to meet our June 22nd deadline for our operation system going live. As a result, we entered into contract negotiations with Conduent to continue assuring that Medicaid, our MMIS system, which handles all of our claims, all of our payment processing for all of the providers out there, especially important now during the pandemic, would continue to operate. And so we submitted the request for approval back on May. And I'm pleased to report, due to the extraordinary efforts of our teams in procurement and contract management, as well as information management, we were notified on June 8th by the, excuse me, the Centers for Medicare and Medicaid Services that the system was in fact approved. Our contract, we have an additional 3 years, and that provides assurance to not only the agency, but our members that we're able to continue operating as we work to still implement our MED system. Next slide. I want to pivot now to our forecast, our financial picture, and the remaining slides, the remaining 9 slides are going to speak to that. You're going to see 3 specific slides right here that show our forecast versus our actuals. Again, for those folks that are new to the board, each year in November, on November 1st, the agency presents its official forecast to the administration as well as our friends at the General Assembly. The forecast identifies what we expect our membership enrollment to be for the next year as well as the next 2 years, the out years, as well as how much money we expect to spend. Obviously, this is a significant portion of the Commonwealth budget, and so dedicated resources are significant attention is put towards this. As you can see so far for FY20, and our state fiscal year begins on July 1st, the green and blue lines show our expenditures. So on the left-hand side, the axis shows expenditures in millions of dollars. And on the right-hand side, it shows enrollments in thousands, and that reflects the red and orange lines there. So on the blue forecast, that's what we believe would happen. And the green line shows what actually happened during that time period. And so you'll see, just as our green line tracks along with the blue line, that everything seemed to be tracking well right up until March 20th. And our expenditures actually dropped below what we thought we were going to spend. And that's primarily attributable to two factors, one of which is a small portion of which is COVID, but a larger portion is actually pharmacy rebates. This year, we forecast how much money we're going to receive in pharmacy rebates. The importance of that is that whenever we get pharmacy rebates, we're able to use those funds instead of general funds. General funds, of course, are the revenues we collect from payroll, taxes, and things like that as a Commonwealth. And whenever we're able to use pharmacy rebates, we reduce and create downward pressure on our general fund so that we're able to save those dollars and it can be used for other purposes inside the Commonwealth of Virginia. And so as you can see there, our green line significantly dipped below our blue line, our forecast, because we only expected in base Medicaid, this is our traditional Medicaid, not expansion, we only forecast to get $297 million in pharmacy rebates, but we actually received $453 million in pharmacy rebates. So that's $156 million more dollars than what we expected. And because it's base Medicaid, it's a 50-50 match between the state and the federal government. So as a result, it's returning $78 million in general funds that we didn't expect. And so that preserves that fund strategy there. If you look at the other lines on enrollment, because again, we forecast what our enrollment is going to be for each year and the out years, the two out years, as I mentioned. The orange line is what we forecasted enrollment to be, and the red line is what it actually was. And as you can see there, you see a divergence from what we expected to the actual, and that's from the observed to the actual, and that's primarily again because of COVID-19. One fact that I will mention that's really important to note is that the federal government back in March decided to, just as it did during the Great Recession, provide enhanced federal medical assistance percentage, which is affectionately known as FMAP. We call it FMAP. And what that does is they increased it by 6.2%. So currently, for every state dollar the state puts up, the federal government matches it by $1. That changed when they added a 6.2% increase to what they were giving us for this year. And so that actually translates this fiscal year into $318 million. But as a condition of receiving that money, and you'll hear more from the Deputy for Administration, Rachel Pryor, in a few moments, we have to continue enrollment of our existing members called maintenance of effort, or MOE. That's why you see the red line continue up there, and it will continue until the emergency order expires. And again, Rachel will speak on that a little bit more. Next slide, please. This shows a similar picture in Medicaid expansion. Again, the blue line is what we forecast. The green line is our expenditures year to date. The same thing happened in Medicaid expansion that happened in base Medicaid. In this case, we didn't forecast any pharmacy rebates because we didn't have enough information. Again, recall, as Director Kimsey just noted, Medicaid expansion occurred under the chairman of the board, Rubin. That just came into being January 1st of last year. We don't even have yet a year and a half of experience. As a result, we didn't predict any pharmacy rebates. But surprisingly, we received $55 million in pharmacy rebates. Again, we're required by the Appropriation Act. It's Part 4, Section 1.01C, to use revenue before we use any other general fund resource, et cetera. And so in this particular instance, we're again seeing expenditures that are below what we forecast, again, because we received more revenue than we expected. On the enrollment picture, it's a little different than what you saw in basic Medicaid, in the sense that Rachel, Deputy Pryor, did an amazing job with open enrollment, as you can see there. Our numbers in expansion increased significantly dating back to November, and again, continue at a steady high level, again, because of maintenance of effort. Again, that's due to Deputy Pryor and her team working together. So next slide, please. When you combine base Medicaid and expansion, you see overall that our enrollment obviously has increased, but contrary to expectations, our expenditures have not. I've mentioned one of the key reasons was the pharmacy rebates, but another reason that I should note, and again, Deputy Pryor and the other deputies will speak to this, the COVID-19 experience, obviously with the governor's declaration of an emergency and the stay-at-home order on March 12th, earlier this year, resulted in the postponement or cancellation of a lot of elective surgeries. And so we saw a decline in fee-for-service that I'll actually speak on another couple of slides, but I did want to note that here. So next slide, please. I want to pivot really quickly to our administrative expenditures. Again, there's our medical budget of approximately $16 billion, but we also have an agency administrative budget of approximately $270 million. Again, that includes federal funds, revenue, and as you see here at the bottom of the second column, $62 million in general funds. Again, general fund is the state's piece that is watched greatly because that is the dollars that are earned from payroll taxes, et cetera, that fund the Commonwealth operations, as Director Kimsey noted earlier, and we pay close attention to that. And so you'll note there that we're actually ending the year after a $3.5 million pledge of savings to the Department of Planning and Budget with just a little over $200,000, $223,000. And to explain a little bit more about the pledge, again, on April 1st, Chief of Staff Clark Mercer, who works for the governor of the administration, sent out a memo to the agency. Director Kimsey then forwarded that to her staff, the executive leadership team, where we received it, and it noted that all discretionary spending and a hiring freeze was implemented, as Director Kimsey noted earlier. As a result, we accrued we didn't expend all of our budget, which is the reason why we're returning these general fund dollars again after expenditure of all revenues prior to that. So we have made that pledge to the Department of Planning and Budget of returning approximately $3.5 million. Again, no prepayments, no advance payments. Again, keeping strictly in line with Clark Mercer's April 1st memo to the agency to eliminate and stop discretionary spending. So we are hewing extremely as close to the policy and the line as humanly possible. And we want to make sure we're keeping straight on that line. Next slide, please. Pivoting back to our expenditures, I do want to speak really quickly into some of the reasoning behind why our expenditures dropped. Again, I mentioned pharmacy rebates, but it's important to also note, as I mentioned earlier, the COVID-19 experience. Again, after Governor Northam's executive order on March 12th, we saw a decrease in our fee-for-service population expenditures. Remember, fee-for-service is only 5% of our 1.5 million member Medicaid member population. The remaining 95% are in our 6 managed care organizations. So as a result, you see here, this is sort of a glimpse on the inside. You see dental reimbursements drop off precipitously after that March 12th announcement. You also see that's actually the most steep decline, serious decline. You also see a decline in our day support, our DD waivers. Physicians declined readily until about April or so, right when the administration, it looks like in May, they lifted, obviously, the ban on elective procedures. If you will recall, and hospitals were allowed to start a lot of the outpatient procedures again. So physicians ramped up back in May, but still haven't recovered to the initial high levels that they were. And then you see the same with hospital outpatient. Next slide, please. Converse to that, you see our enrollment, of course, increasing. The two slides where you see age and disabled and children, and base Medicaid. Those are in our, again, base Medicaid program there. You see the increase there primarily attributable, again, as Deputy Pryor will speak into in much more detail, our maintenance of effort, a requirement of acceptance of the 6.2% match, the increased FMAP. We maintain these folks. You see the same as well for our adult-based Medicaid and adult and Medicaid expansion. Next slide, please. And when you look at the total there for the actual amounts that are shown for each of the fiscal years, you can see that the federal, enhanced federal FMAP amount for FY20 is $318 million. Again, in FY21 for the whole year, it's $663 million and $708 million for FY22. And what that would practically mean for the state is when the federal government gives us that money, it allows us to substitute those funds for general funds so that the Commonwealth can make appropriate decisions on utilizing those funds, recognizing the fact, as Director Kimsey noted earlier, that we're looking to be $1 to $2 billion short in revenue. And so this is sort of an antidote, if you will, to counter that impact. So next slide. This is a very high-level profile view of our DMAS agency year-end medical balances. Again, I mentioned earlier, we have a $16 billion medical account that we use to fund all of the medical care for all of our members, our 1.5 million Medicaid members. The key pieces I want to point out to you are line 2 and line 5. Line 2 is famous, line 5 is Medicaid. If you look in the second column there, that shows our general fund appropriation. Again, the federal government makes up the bulk of our Medicaid program. The general fund makes up the remaining portion of it. In our famous program, which is again for women and children, you'll note there that the dollars that were appropriated for that were $33 million in general fund and $14 million in our dedicated special revenue. It's important to note that we will exhaust all of our dedicated special revenue before we utilize any remaining general fund dollars. So we'll actually have $333,000 general fund dollars in DMAS to return. And so true on Medicaid, line 5. If you look and note there, we were appropriated $4.7 million to spend in general fund. We were given appropriation to spend $408 million in our Virginia Healthcare Fund. That represents revenue from tobacco settlements, as well as the pharmacy rebates I mentioned earlier. Again, we will exhaust all of our revenue pursuant to Part 4-1.01, paragraph C of the Appropriation Act, to make sure that we spend all of our revenue before we, and to conserve all of our general fund dollars. And so we will be returning an estimated $83.7 million in general fund back to the state. Next slide. As I finish off the next 2 slides, I just want to speak as we move forward. As I mentioned, 95% of our members are in our managed care organizations to receive wraparound services. And so when we look at that, we have an excellent slide there that shows our major process that we undertake each year, where we basically look to see how many individuals and how much collaboration we can do with our plans, such that we make sure that we have contracts online and ready to go July 1st. And I'm pleased to present that or report that on June 1st of this year, we actually solidified our rates to and notify the Department of Planning and Budget as well as the money committees. And we were able to complete our FY21 rates for, again, all of our managed care organization plans. And we are very close. We're working with the Department of Planning and Budget to finalize the contracts so that we can, again, send those to CMS for approval. The last slide that I'll speak to, and being very mindful of the folks that are coming after me, this is actually, even though the title of the slide is Provider Health Information Breach Notification, it's actually a good news story. Karen, can you still hear me?
Yes, I can still hear you.
Okay, sorry. Yep, the computer shut down, so surprised on that. But last slide. I did want to, this is a good news story. Our hospital systems, unfortunately, were the target of a cyber attack earlier in December and January, our hospital sector in Virginia. They gained unauthorized access to passwords that enabled them to gain access to change banking routing information for our conduit payment system, which again pays all of our providers in Virginia funds in return for the medical claims they submit. And they were able to steal approximately $580,000. And we found out very quickly. And as mentioned earlier, the theme of collaboration kicked in. We established within the agency an incident command structure that involved not only almost every single part of the agency, but also externally, the Department of Planning and Budget, VETA, Department of Accounts, Department of Treasury, the Office of the State Inspector General, the Virginia State Police, as well as the Auditor of Public Accounts, the Federal Bureau of Investigation, and the Department of Treasury Secret Service at the federal level. And so we involved all of those folks, and due to the swift efforts, I'm pleased to report, we were able to recover all of those funds due to the Virginia State Police. And as a result, we were able to make those payments. Unfortunately, in the process of absconding with those funds, the hackers also gained access to protected health information, or PHI, for 6,120 members. And the good news is we swiftly jumped into action, worked with our partners, again, sister agencies, DSS, Cover Virginia. We worked with our managed care organizations, and we notified each of our members by mail as provided by law. We notified the federal government, HHS, OCS, on March 9th. We notified every single one of our 6,120 members. Again, that effort was curated by Deputy Pryor and her staff, as well as Christina Knuckles, our public information officer, did much of the outreach, and we published notification both online on our website as well as in our newspapers. We set up a pop-up call center to handle any calls. We received 400 calls from folks, and we also set up 1-year credit monitoring, credit service monitoring with Norton Lifelock, and 45 people enrolled in that. That concludes my presentation. I have 3 slides that are appendix related to the items from FY21 and 22 budget, the biennial budget that were unallotted. But I'll stop there because there's much more information. So Director Kimsey, I'll turn it back to you.
Yeah. Does anybody have questions on this, or can we have Kris stick around if the presentations are integrated into what's coming next?
Mm-hmm. Mike, I have a few questions, but I can wait for the other presentation. Thank you.
Okay. The next
Yeah,
person.
I have a bunch too, Kannon, but no.
Okay. Well, what we can do is, and it perhaps there may be some components, as our chair was mentioning, that might be also addressed through either Rachel's presentation or Tammy's. And so we're going to turn it over next to our Deputy Rachel Pryor. Thank you, Kris, for your presentation. And Rachel, it's yours now. And Valerie, it's okay to go ahead and bring up the slide. There you are. Okay. My apologies today. We've been experiencing this week some delays with Google when we're taking action, and it takes a few seconds for it to catch up.
Oh, here we go. And I think I'm off mute now. Hopefully I was attempting there.
We can hear you.
Awesome. Wonderful. And I want to say a big thank you to Dr. Rubin. She's been a wonderful partner to us, and I don't know if she's still on the phone, but you know, she is. I heard through the grapevine moving to carry her message forward to the United States Senate, where she'll be testifying before the Health, Education, Labor, and Pensions Committee up there on telehealth and COVID-19. And she certainly has been a huge part of our program and helping us get to this point, as Karen mentioned. So appreciate that, and a welcome to our new board members. Thank you for having me. My role at DMAS is a couple-fold. I generally manage policy regulation policy and regulation and legislation, and then also separately oversee our eligibility and enrollment operations and our appeals operations. But the focus for today's presentation is really on our COVID-19 response from a big picture policy point of view. So we can go ahead and go to the next slide, Valerie. Thank you. Okay, great. So just to, run through our sort of overarching strategy. As folks know, as a lot of you folks know, Virginia, well, all Medicaid is a pretty complex program compared to other programs under state and federal law. It's jointly regulated, which means we have federal law we follow, we have state law we follow. Sometimes they interact, sometimes they don't. Federal government pays for over half of our program. So and then there's a huge general fund impact, of course, where Medicaid's concerned. So developing a policy strategy gets pretty complicated. We just by the numbers, what we've done, we've had 2 executive orders at the state level, 86 provisions of our state regulation waived. I want to caveat that and say, often when we're waiving one reg, it's referenced in another reg. So it's not necessarily 86 different provisions, but it is 86 provisions of law that needed to be waived. 6 provider memos. I think that number's even gone up since we've done these slides. We filed 9 federal regulatory waivers, and we've developed, as Karen mentioned, a COVID-19 landing page to both our dmas.virginia.gov and our Cover Virginia websites that include resources for advocates, providers, and our members. I encourage you to check out both places. They contain different information, but all incredibly valuable in terms of seeing what we've done. There's one-pagers, there's listings of the regs that we've waived, there's information for our beneficiaries and application assisters. And so I think, I would commend the Chief of Staff's office that's worked with my team and Christina Knuckles for their hard work there. We can go ahead and go to the next slide. Couple provisions from Congress that have helped us that I won't spend too much time on, but we did get a 6.2% increase on our FMAP that is contingent on 2 separate provisions. So they often get combined into one. They are 2 separate things. There is a maintenance of effort provision that requires us to keep our benefits and coverage and eligibility standards in place until the end of September. That means doesn't matter what happens at the state level. In order to keep that extra funding, we are going to need to maintain eligibility standards and benefit standards until the end of September. We also are required to maintain coverage for anyone that had Medicaid coverage and normally would have cycled off the program. After the president's declaration in March, we are required to keep those people on our program until the end of July. So that is what's commonly known as the continuous coverage provision. There is the COVID Relief Fund, which is approximately $3 billion-ish that goes to states. States are broadly parceling this out. It is not Medicaid only. So the certification component that you talked about, Michael, I think is related more to the Provider Relief Fund. That's where a provider is interacting directly with CMS, and there's been quite a bit of confusion around certification requirements. The providers do have to certify a couple different things around lost revenue and COVID expenses that have been quite confusing. And then there's across, and this isn't actually only in the CARES Act, there were 3 big bills that Congress has done so far, 3.5 really, if you count a little one they did on the end there. There's been, more than 180 billion in what we call at the federal level discretionary spending. So not mandatory, not open-ended, doesn't just flow, but all the same very helpful to state and local governments. We are hearing that there may potentially be a 4th stimulus package on the way. Really depends on where we're at. I think everybody's very anxious to see if Secretary Azar extends his public health declaration, and if the president extends his Stafford Act declaration. I think that will determine a lot of what Congress does next. So we can go ahead and go to the next slide. So just to go into detail about the different authorities, we have filed, part of my role is, I always say, is to really figure out the how. So states broadly have a lot of flexibility in what they can do in their programs. under federal law and depending on your state, under state law. But, you know, really it's figuring out how, what needs to be moved, what authority needs to be waived, you know, how do you legally enact that flexibility. For us, we identified in our programs and our program staff across the agency worked very hard to identify what they thought from a program perspective really needed to be moved to support our members and to support our providers. Those flexibilities across the whole agency took the form of several different regulatory pathways. I won't go through these in detail. I'm happy to answer any questions about them. You know, it starts to get really complicated, and I know that I don't have a lot of time and we have a lot of presentations to get through, so I won't spend a lot of time here, but suffice to say, you can see the different authorities. They are generally authorized under different provisions of federal law, whether it be the President's declaration, Secretary Azar's declaration, dependent on your state declaration. So depending on what the authority is and what you're trying to waive, you kind of have to go about it in a different way. So we can go ahead and go to the next slide. And this is just giving you a timeline. We worked very hard. I think a lot of people would say they would like us to have gone faster, but we did go as fast as we humanly knew how. And I'm proud to say that this multitude of federal authorities happened over, you know, virtually a less than 2 month period, and we are, you know, we're sort of rocking and rolling, for lack of a better term. We've received approval on everything except for one. Next slide. Just to kind of, as I mentioned, there's the state component too, always with Medicaid, right? So the feds authorize, you know, sort of broad requirements. States design their programs, design the delivery of the programs within those broad federal parameters. If you've seen one Medicaid program, you've really only seen one Medicaid program. They're all very, very different because of that. So we here at the state level have been working very hard to make sure that not only do we have the federal flexibility we need, but that we've also sort of worked with our partners in the General Assembly and in the rest of the executive branch to figure out what we need to do to clear the way under state law. There's been 2 executive orders, the one that everyone is familiar with, which applies across the Commonwealth and gives us the authority with the approval of the governor to waive certain provisions of our regs. Executive Order 58 is specific to Virginia code that, you know, requires a separate executive order. And then also, as folks saw in the most recent budget, there was support for a couple different things, you know, including nursing home increases, as well as allowing us to move a little more quickly with the approval of our partners to gain additional authorities needed from the feds. Next slide, Valerie. I want to talk a little bit about eligibility enrollment, because that is an area that is obviously very, very close to my heart, and you can't even begin to make sure that people get the services that they need if they don't actually have health insurance. There's no real access without health insurance coverage. And so a couple things that we did sort of very immediately right off the bat was to make sure that we kept everyone in, and thankfully keeping everyone in meant we got additional money, which was a good thing. We've eliminated cost sharing in our program. Frankly, our cost sharing policy is a little bit out of date anyways, and certainly would be very bad during an emergency. So we've eliminated all cost sharing. We've continued coverage. We have waived renewal deadlines so that, and this is partly also for our eligibility staff, our eligibility workers who are now rapidly working remotely and are not accustomed to that. And so it was important to also free up our workforce as well. We have, gotten approval to delay acting on any changes in circumstances. So if somebody's has a, their income changes or something like that. We're not acting on those things right now. We are just sort of frozen in time as of March to make sure, to make sure that everyone maintains their coverage. And we are, and that allows us too to free up our eligibility workers, free up Cover Virginia to handle the influx of new applications that have come in since people have lost their jobs. Importantly, Medicaid has no open enrollment period. It is there when you need it with no waiting period. So when you lose your job, you can apply for Medicaid, and we have seen that happen. Next slide, please. Also want to talk a little bit about appeals because it's another area that's very close to my heart. We have automatically continued coverage while somebody is requesting an appeal during the COVID-19 emergency. That is an option for beneficiaries currently. We went ahead and made it a policy across the board while they are seeking due process. We are holding all of our hearings on telephone. We are broadly allowing for reschedulings. Our providers can request a hardship exemption to the normal deadline to file an appeal. We have extended deadlines on our side. Similarly with members, their deadline to file an appeal has been extended. And similarly on our side, we have approval from the federal government to push those deadlines out on the back end as well. So that's been something that we have received a lot of feedback on as being important. I will say other changes made on the program side to extend or waive certain service authorizations has helped us to keep our appeals down. And again, that frees up our hearing officers and the folks that are processing the appeal to make sure that they can keep up and keep up remotely with an operation that generally at DMAS has been very paper-based in the past. Next slide, Valerie. A couple additional member improvements we just wanted to call out for you. We did create a new Cover Virginia consumer inbox. This will be permanent. We will not change this. It occurred to us that it might be nice to let people submit needed information we're asking for from them by email. We did not have that functionality in place, so we have changed that. And we've also gotten approval from the federal government for an authorization for verbal consent. This is important because folks just do not have access a lot of times to certain documents or things that they need. We usually have to get a signature on a piece of paper to allow someone to help someone with an application. And, that just really slows people down in an emergency. So we think this was a good change for us to make for COVID-19. We can go to the next slide. And this is, this is the one that everybody asks about. We had a great open enrollment, super successful, got a lot of folks in the door, got them in timely. The team did a great job there. Since COVID-19, they have been working very hard. We have the application channels, because we're pushing a lot of people to online applications. It means our Cover Virginia central processing unit is really way above volume, and they are working super hard to stay up to speed. They are right now, but it is a constant struggle to kind of process as fast as you can. We have a total of more than 1.6 million members right now. You can see the numbers here, they're self-explanatory. More than 73,000 members have enrolled. I think that number is even higher, actually, since this slide was done. We may be in the 80s now at this point. And you can see the impact of expansion here, right? If the state had not expanded, we would be in a much worse financial place. We'd be in a much worse human place. Right? Because these people would have nowhere to go, and our providers, frankly, would not be getting the reimbursement that they need for treating them. So it's twofold. There's a first order effect and a second order effect there. And children, I think, is always something to point out. People forget that Medicaid is the largest insurer of children, full stop, end of story. And that has certainly been an impact when you've got kids, out of school, parents who have lost their jobs. That means their kids lost their health insurance. And so we've been able to help which is something that I know is really meaningful to everyone, everyone who's engaged in Virginia Medicaid. So with that, I went super fast, and I will stop talking and let my colleagues continue on, because I know that we are already low on time, but happy to take any questions that folks have. Thank you.
Karen, question again. Can your folks stay a little bit later so that we can move through the questions and so that we can move through the presentations, or do we need to have all the questions now?
Well, I think if the team, maybe about 10 to 15 minutes over, I'll try and see if I can shift another call and see what we can do to accommodate. But, our apologies, this is our first time too, also doing virtual. So if we have to do another, we'll work harder at being more on time too. So.
Is there anyone on the board who can't stay an extra 10 or 15 minutes who has questions of either Rachel or Kris at this point? Okay, thanks. Karen, do you?
Yes. Okay, thank you, Rachel, very much. And for those of you not aware, our Rachel is expecting her second child, and we're very, very excited for her right now. And so thank you, Rachel, for all of your leadership in this area. She has done a phenomenal job. So, okay, so now we're turning it over to our Chief Medical Officer, Dr. Chetan Bhattacharya. Chetan, are you on?
I am. Yep. I imagine I'll be seeing the slide shortly. Great. So before I jump into the presentation, I do just want to acknowledge the board and the leadership and everybody really at DMAS. So congrats to the new board. Profound thanks to Karen Rubin, and some of the work, actually not some of the, a lot of the work you'll see today and certainly in my presentation has been inspired, supported by Karen. So definitely appreciate that. And then, and so we'll jump right into it. Next slide, please. All right, so today I'll just be covering a few topics, and I'll try to be concise in the spirit of ending on time. And so we'll be talking about the COVID-19 crisis, providing a brief update on testing, and then talking about how we're working to empower patients and providers during this really complicated time. Next slide. Thank you. So this slide may be a few days old, and for those of you who like data or interested in the numbers, when it comes to COVID-19, our public health colleagues have really done a phenomenal job in terms of collecting and presenting the data, and this is from their website. And so you'll see some of their figures in the next few slides, and you can take a look at not only testing, deaths, what are the goals, but then also you can drill down, and we'll do that over the next few slides. The most important really point here that I want to make, well, actually a couple points. So first is that, believe it or not, it's been about 3 months since Virginia had its first case, and what a 3 months it has been. And in Virginia, what COVID-19 has met is certainly social distancing, but it's also met a really profound toll in terms of hospitalizations, in terms of deaths, and in terms of a lot of fear and anxiety, not to mention the economic consequences that it has had. The measure that I look at most closely when I'm trying to wrap my head around COVID-19 in Virginia and across the country is really number of deaths. Really that's the ultimate metric. I do that because testing is a little more complicated, not just in Virginia, but across the country, really to be able to get to everybody who does have symptoms and who does not have symptoms, tested in a timely fashion is a really challenging task. And so death and hospitalizations are really the most reliable metrics, again, in terms of thinking and looking at COVID-19. And for us, the peak of our death toll was a little over 41. And you can see that at end of April, beginning of May. And then most recently, it's come down to the daily count of around 10 to 12. And so there has been, thankfully, a decline and social distancing has really had a positive impact. Next slide, please. Now, this slide I think is very important at all times, and particularly now as we're grappling with the historical and structural inequities in our country. And really, this is about who is impacted by COVID-19. And so, yes, it's a virus, and some have called it the great equalizer. I think, a virus in a vacuum does affect folks for the most part equally based on biology, but in our society, it's quite different. And, the virus has traveled along the fault lines of our society. And so I think of COVID-19 as the great revealer. And you see that in the data here. And so really what COVID-19 has done and has, shown a spotlight on is who's most vulnerable in society. And so the over 50% of deaths from COVID-19 have been among our long-term care community, particularly those in nursing homes. When we look at, and you can see in some of the figures that COVID-19 really impacts urban areas more than rural areas, Northern Virginia, Richmond, Tidewater. And then finally, COVID-19 has really disproportionately impacted marginalized populations such as the Hispanic population and the African-American population. To give you a sense of the scope, in Virginia, at least about 10% of the population is Hispanic, and yet the Hispanic population accounts for almost 50% of all confirmed COVID-19 cases. Similarly, for the African-American community, which comprises about 20% of the population, they account for 30% of all COVID-19 cases. And, I think these data, and certainly the past few weeks, I know, and we've been talking about this internally and externally, is how they demand much more of us, really, to not only understand these data, but then also respond. And I don't think it's on the agenda, but I just wanted to really highlight, and maybe Ivory or Karen would be better than this, but I want to highlight the work that Karen Kimsey and our Chief of Staff, Ivory Banks, have been doing in their leadership in both acknowledging the challenges of sort of equity during this time of COVID-19, and then working as an agency to figure out how we address it, acknowledging that it's hard work, but that it's necessary work. And so just wanted to give a little shout out to them. And if we have time, would love for them to say a word or two on that. Next slide, please. And so this is, wanted to show this slide really to reflect how we think about testing at DMAS, is that ultimately testing is a collaborative effort between public health and our healthcare system. And so COVID-19 is new, right? And so our providers, our healthcare providers, don't really know, aren't as familiar with COVID-19. And so part of the work has been collaborating with public health to translate guidelines and guidance from public health into action on the ground for our clinicians to ensure that for our members, that they have access to clinical guidance, advice, testing, and ultimately treatment for COVID-19. Next slide, please. And so we've started to do this by really taking the frame of how do we activate providers in this effort. And so one of the most, I think, important things we did recently was partner with our FQHCs to, they're a critical ally and, for our members and for all of Virginia in providing care regardless of payer status. And so we partnered with them, and as of March 27th, and this number is increasing, 31 FQHCs offered reliable testing sites in the Commonwealth, meaning that they have a direct supply chain from that's sort of guaranteed by the state, and they're able to offer testing and accept all comers, again, regardless of ability to pay. And another 37 are coming online. And the goal is to have, just with the FQHCs, 70% of the geography of Virginia covered by this one partnership. And there are so many more that have been forged over the past few weeks. And as you can see with the public testing sites, in March 20th, we had about 27. Today we have over 300. And certainly we're working to and collaborating with public health in our healthcare system to expand to more and more testing sites, but that we've had made some tangible progress over time, which I think is really important, and will continue to do so over the next few weeks and months. Next slide, please. In addition to activating providers, we're also very, I don't want to say obsessed, but we're very focused on members as our core mission, and as really what drives us to do the work we do at Medicaid. And so we think a lot about how do we activate members? And you heard it in the prior presentation as well about the policies that we're tweaking and changing to make accessing care easier for our members. And so we're also thinking about this in terms of COVID-19. And so our communications team has been tailoring messages to our providers and our members around COVID-19 and around the benefits we're offering. In addition, we've been collaborating with public health again to figure out, from the point of view of the member, they may feel anxious or have symptoms. How do they access care and advice and testing related to COVID-19? And so through that, COVID Check was born, and that's available now on the public health website. Next slide, please. And what COVID Check really is, it's really a digital front door, a navigation tool for everyday Virginians, again, regardless of ability to pay, to, if you have symptoms or you're afraid a loved one has COVID-19, you can go online, you can check your symptoms, and you'll be triaged to the right level of care. You'll get clinical guidance as needed, or you'll be directed to clinical guidance. You'll be navigated to the closest testing site, to a primary care provider if you have one, to telemedicine if you don't, and to the ER if you need it. And so really the goal here is to be a kind of a soup to nuts navigation tool from the perspective of our members. And I just received some data on COVID Check. In the first 2 weeks, we've seen around 6,000 individuals use the tool, and well over 60% needed care. And so, and about 20% of those, we were able to avoid an unnecessary ED visit. And so the way I'm seeing this is that, really it is an opportunity to meet people where they are, to provide a low barrier means of accessing care. Next slide, please. Yeah, and so this is my last slide, and really it's on telehealth, and one slide does not do it justice. But really this has been one, and I am lucky to present this, but so many other folks in the agency and around the Commonwealth have really made this possible and made this successful. Chief among them, of course, being Dr. Karen Rubin. And so the changes we made in telehealth were early on in the crisis in March, recognizing that care would be disrupted for our members. And so the question for us is, how do we ensure access to care? And telehealth was a natural solution. And so telehealth quickly became an imperative for the agency and for our members. And so the changes we made were a few. One is allowing home as an originating site. And so now patients, members can be at home and receive care. So that's one, and that was probably one of the biggest changes. Another one is allowing telephone in addition to video conferencing, acknowledging that not everyone has access to reliable wireless internet. The third is payment parity with in-person visits. And so you get paid as a provider, you get paid the same if you provide services via video conferencing or phone as you might in person. And really the focus is on the service, not so much the modality. The next is simplified billing and documentation. And this really came from a number of staff here at DMAS who felt very strongly that we needed to not move in a couple of weeks or months, but we needed to move tomorrow and really allow our policies to support our providers and members. And so we made it so that billing and documentation is simplified for providers. And the third and the last two, I'm losing count here, are really around remote patient monitoring and enhanced specialty access for e-consult.
Thank you, Chaitin. I'm just trying to keep mindful of the time. We have Tammy also needing to present. So folks can also ask Chaitin more questions about this after.
Perfect. Thank you.
Thank you, Chaitin. We really appreciate it. And we're going to turn it over in interest of time to Tammy Whitlock to talk about the flexibilities that have been enacted for LTSS. And then we'll open up for questions for you all.
Thanks, Karen. I can go really fast. I'm a fast talker.
Thank you, Tammy.
All right, so Valerie, you can just go to the next slide. I'm gonna push through these. So we enacted a lot of flexibilities for long-term care services and supports, and we had several memos that went out, and I'm just gonna walk through what was in each memo. On 3/19, we sent out a memo, and we enacted the flexibility for service authorization, for waiving service authorization for some waiver services and EPSDT services, and automatically extending those services for 60 days with the provider not having to do anything. We also did the same for specific DME and home health items. We waived a lot of service authorizations for those during the first 60 days. And we suspended out-of-network authorization requirements for the MCOs. In other words, the provider didn't have to be in network in order to waive authorization requirements or obtain the Medicaid fee schedule payment. Next slide. We enacted remote telehealth, as Chethan was saying. We put in place a lot of telehealth capabilities that we didn't have before for home health, hospice, for our waiver reassessments, for service plan meetings, a lot of DME, supervisory visits, things like that. We put a lot of telehealth in place, including telephonic visits for those services. And for our quality sampling, for our quality monitoring reviews that we are required to do by CMS, we were able to get CMS approval to reduce the number of reviews that we had to do. Next slide. We also received on 4/22, the next memo, we put in place the flexibility. We put in place the flexibility that we could require or allow the providers who are residences to not allow visitors into their homes and into their buildings. This is something that they normally would have to do, so we did give them that flexibility. Next slide. And in addition, members, as Rachel said, we don't want members to lose their Medicaid eligibility. We didn't want them to lose their waiver eligibility either. So we put in place the flexibility to allow members who didn't receive waiver services within 30 days, which is a requirement. They did not lose their waiver slot. We did require the MCOs to reach out monthly to do telephone checks on these members. And we were allowed to extend the waiver level of care reevaluations from 12 to 18 months. Next slide. Also in the 4/22 guidance, as Karen spoke of initially, we allowed spouses, parents of minor children, and legal guardians to be reimbursed for personal care services. We also allowed the flexibility for agencies who are normally required to have their aides attend and complete a 40-hour training prior to starting services. They were allowed to go ahead and let that aide start services as long as that aide met the basic skills and knowledge, skills, and abilities for the job, and but they have to complete the training within 90 days of starting their job. Next slide. For, as Karen said, the adult day health and day support providers got retainer payments. We paid up to 65%. We're paying up to 65% of the current rate. The 65% was arrived at by comparing the claims to the service auth, and that was the average utilization percentage for these services. Next slide. We permitted in the 5/26 memo, we got the flexibility to have members who chose to go to a nursing facility out of a hospital to waive the screening for those individuals. We also received the ability to allow the PASSAR, which is our pre-admission screening and resident review, to be extended to 30 days after the person goes into the nursing facility instead of 10 days. I want to reiterate that choice has to be documented for individuals who are going from a hospital to a nursing facility directly. Getting some feedback. Next slide.
Please make sure everybody's muted if you're not speaking. Thank you.
For the MDS, which is the minimum data set assessments that the nursing facilities do, we extended from 14 days to 30 days to give the nursing facilities a little more flexibility on that. And we also allowed the nursing facilities to keep aides on staff, even if they had not completed their certification. During this, the first few months, the certification wasn't even available for them to take, and we didn't want them to lose their staffing. Again, they had to be sure that the person met the basic knowledge, skills, and abilities. Next slide. We waived a lot of flexibilities on home health and hospice for supervision. We did ask that the providers do telephonic supervision, and we allowed the home health agencies to do their certifications and assessments to start services via telehealth if that was possible and if it was available to the member and to the provider. Next slide. PACE sites asked for some flexibility to use remote technology. We allowed that. They are able to do that, but we put in place that they had to document written signatures that were needed within 45 days after the end of the emergency. And they also we also allowed their quality management reviews to be done by desk review, not in person. Next slide. For DME, we were asked for a lot of flexibilities for DME. I'll run through these really fast. We allowed the DME providers to deliver up to a 1-month supply at a time. We put in place the recommendations from NCART, which is one of the national coalitions for remote protocol for complex rehab equipment, such as complex wheelchairs. We allow telehealth visits for the therapy evaluations unless it just wasn't a good thing to do for the member's safety. We took out the requirement for face-to-face visits for authorizations for certain codes, and we allowed short-term oxygen use we allowed the service authorization for short-term oxygen use to be waived. Next slide. We also allowed the certificates of medical necessity, which is a DME form, to be suspended until to extend those until the end of the emergency. And for new CMNs, we allowed that to be suspended as long as there was documentation in place that you see in the last bullet here. Next slide. Karen talked about the $20 a day. I will say that to date, we have paid $11.9 million to the nursing facilities so far for that $20 a day. Next slide. Civil money penalty, we've gotten over 175 applications from nursing homes to obtain this funding for technology. This is basically for iPads and some phones to allow the members to communicate with either their physician, their specialist, or their family to make sure that they can communicate with their families during this time. Next slide. For behavioral health, we allowed all these services that you see on the slide to be done via telehealth, which was a tremendous benefit on the behavioral health side. We saw quite an increase in the behavioral health services, especially the outpatient psych services. Next slide. This is just a diagram. We worked with DSS, VDH, and DBHDS to come up with a decision tree similar to what was done in Alaska on when telehealth is a good idea. So I'll let you look at that at your leisure. It's too small for me to read right now anyway. Next slide. And for arts, we allowed the opioid treatment programs who normally have the person come into their facilities, their offices every day. We allowed them to dispense a 28-day supply and still bill us for the daily the daily services that they would normally do. This is to help cover the nurse dispensing and the pharmacy dispensing fees. We allowed the counseling component of medication-assisted treatment to be done via telehealth or telephone. And we're not penalizing OBOTs or OTPs if they miss if the member misses the urine drug screening right now during this emergency. And of course, we waived the face-to-face contact requirements for care coordinators and counselors. Next slide. We are allowing some provisions around behavioral health authorizations so that they can submit those after the service starts to go back to the beginning, back to the requested date. And we're also allowing individuals who are unable to be discharged from an inpatient psych hospital due to concerns of COVID in their community. They can stay in longer in the inpatient psych care and still get authorization for those services. And lastly, we allowed some flexibility in out-of-state licensed mental health professionals to be allowed to practice in our state, even if they didn't have a license in our state, but their license was comparable in another state. And this drastically increased the number of LMHPs that we had available for our members. Next slide. I think that's it. I'm done.
Thank you, Tammy. We really appreciate it, and all of your leadership to you and Chaitin and Kris as well on this. And so, Michael, we are able to turn it over to you now. Questions?
Any board members with questions? I suspect there are a few out there. Now would be a good time.
Yeah, Mike, I have a couple of questions. I'll go through them quickly. My questions are for Kris, our CFO. So the $453 million, Kris, that you had mentioned that we had to split between federal and Virginia, do we expect that to happen next year? Is it a year over year? Do we expect the same 450 million?
Thank you for your question. So the 453 is, again, just to refresh everyone's memory, 453 million is the amount that we received in pharmaceutical rebates, which was $156 million more than we expected. So yes, we expect to get pharmaceutical rebates. This year, we forecast 297 million. Because we received 156 million more than what we expected, we will update our forecast for next year. The challenge with doing pharmaceutical rebates forecasting is not so much the current year adjustments, but prior period adjustments beyond the current year. And so pharmaceutical companies, there is a lag in claiming information and submitting that. And so we work very closely with the Office of the Chief Medical Officer's staff. He has the pharmacy division that works with his team. And so our goal is to make sure we tighten that up. The good news is it's on the positive side. It's more than what we expected. It saves general fund dollars. That's good. But getting better predictability around it so that those, in this case, it would be $78 million, could be put towards other purposes is obviously in the interest of the Commonwealth. And so my team is aware of this and will put time and effort towards researching how we can get better data.
Awesome. Kris, I have one quick question related to pharmacy benefit. The 55 million that we got for the expansion group, do we have to share that 50% with the federal?
No, in fact, the matching rates for Medicaid expansion, and that's why I presented it differently, are on a separate slide, are in fact different. As you know, 90% of expansion dollars are provided by the federal government, and then 10% is coverage assessment is provided by 69 private acute care hospitals that we collect assessments from or tax. And so in this particular case, it will offset the burden of the coverage assessments that we collect from those 69 private acute care hospitals. And as a result, it will lessen the amount we have to collect from them in FY21, which is good because we know that hospitals are the front lines along with nursing facilities. So it'll reduce their cost burden as well.
That's awesome. And I have one final question, Kris, and thanks for answering this. The drop in claims, I understand only 5% of our members are in fee-for-service and 95% is in MCO, but would that benefit us in their rates or assessment of rates or calculation of rates? I'm just thinking, I'm in the insurance industry, we are seeing it in the last 3 months. So I was just wondering, how does that impact our managed care agreements or rates or financials, or how does that flow to us, whatever benefit for a few months?
I will answer quickly, but then I'll defer over to our Chief Deputy, Dr. Munn, who's actually done a lot of research in this specific area. But obviously, just if you drive a car and you have car insurance, all of the car insurance agencies have given refunds or money back to folks. In a similar sense, as managed care organizations are an insurance agency, insurance company, we have been providing our continuous per member per month payment to them. Sure. But as I noted earlier, because of the deferment of those elective surgery claims, et cetera, all of those things have dropped. The managed care organizations are cognizant, and some of them have actually come to us and said, how can we invest more money and provide directed payments within Medicaid? But Ellen, Dr. Munn has done a lot of additional research, so I'll defer to her.
Thank you.
Yeah, thanks for that question, Kannon. And I think, we all, we can see it with our eyes. We don't even need to see it with data, that, in fact, our utilization has been down, particularly over the last 3 months. And that means, we're paying our managed care plans capitation rates that were based on previous utilization. And we know that utilization has not come to fruition. So a couple things there, right? Our current rates, capitation rates are in effect until the end of June. So the end of this fiscal year. And doing nothing, if DMAS and the Commonwealth did nothing at all, that would mean that we would expect in about 12 months time. There are ways that we could actually make that less time, but we would expect in kind of 12 months time that we would get that rebate that Kris is talking about. So we all know that we have a state policy that applies profit caps to our managed care plans. Now, obviously, when we get that rebate, we have to share that rebate with the federal government. So, we are thinking about, a few policies. We implemented the nursing home rating increase per diem. We implemented that under the existing capitation payment rates, right? So we didn't put any additional money forward. We asked them to kind of pony that up, totally reasonable. And we are thinking about ways that we might try and kind of spend some additional dollars that exist underneath the exist in our current capitation rates, kind of retrospectively and before the fiscal year ends. So we're working on that with the administration. CMS did recently put out some flexibilities. It was very recently that they did so it is hard to kind of take advantage of those, but we are working. In our future rates, I think we can expect, our actuaries are kind of saying, look, we expect the utilization kind of decreases to continue a little bit into the next fiscal year, but on balance, that'll probably come back up, whether that means that it increases, to a, that we're seeing kind of pent up demand and we get a little bump, that could kind of, they're expecting that to kind of balance out. And so, our rates for the next fiscal year, we've done our rating meetings with our actuaries and those look pretty stable. So, I could talk days about this, but I know. Happy to talk more offline, but
Thank you. Very nice. Thank you, Dr. Mons. And I was just, I got $33 from my insurance company. That is on my personal side, but on the work side, this is what I do all day long. And we have been doing a ton of modeling in our business, and it's a pretty interesting issue. So thanks for the update.
Yeah, Karen, I know we're late, but do you have time for Maureen? Maureen, why don't you go ahead?
Yes, sir. And before Maureen, my apologies. I will have to step off around 20 after 4, but Dr. Mons has agreed to help and support in the meeting.
Thanks. Great. Thank you.
The
Marie?
presentation from Rachel Pryor on slide 7 states that with the continuation of coverage that you've waived out-of-pocket expenses for members. Does that apply to patient pay?
Rachel, you're on mute.
You're on mute, Rachel.
Oh, sorry about that. That is a very good question. Patient pay has been very tricky, frankly. And so I believe that we have applied it, but I actually want to get back to you on it because I know that my division director on eligibility enrollment has been working with Tammy's team, and they were actually having a meeting about this the other day, and so I don't want to tell you the wrong thing. So let me circle back with you on sort of the final determination, but patient pay does get a little bit tricky, so I don't want to, when I said out of pocket, I was talking specifically about copays, not necessarily patient pay, and then spend down works a little bit differently as well too.
Thank you. If we could get that information, Michael, that would be helpful. And I just have one more thing, Michael, that following up on the presentation that Tammy Whitlock did on slide 8 and talking about the screening for individuals to leave acute care settings and move into nursing facilities during COVID. We are very concerned about this process, not so much that if the process as is allowing individuals to leave an acute care setting without a screening to determine their need for long-term care and to move into nursing facilities without that screening. During the time where we know that there are problems occurring at a higher degree in nursing facilities and not allowing that same process so that if an individual wants to leave the acute care setting, the hospital, and avoid a nursing facility, but they desperately need personal care in their home to be able to leave, they have to wait 30 days for that screening at home without services if the acute care facility does not do the screening prior to discharge. And we know historically that the hospitals have not been doing those screenings when needed at all times. And so with the pressure on hospitals to discharge, it is a much quicker and easier discharge to a nursing facility than to the personal care that an individual may need to be able to safely return home. I don't need anybody to respond to that. I just needed to say that. Thank you, Michael.
Sure. Anybody else with questions? I have a couple, and I'll try to be brief, and you can let me know if you want to deal with this offline. A broad question that I'm sure you can answer in about 30 seconds. For the next fiscal year, we're having fewer revenues, as we know, coming in, although we don't know exactly how much. Have we given any thought as to how we're going to handle any cuts that we may have to make at the behest of the governor? And is there a time frame when you're going to be submitting some of those?
Yes, sir. This is Karen. We are preparing just in case there are budget cuts in the future. And we're already modeling what those cuts may look like for the administration's consideration. But we're not sure at this time what, if any, of those percentage cuts will need to be taken. We are ever hopeful that the economy will turn around and improve. And if it does, and there's discussions about a special session to be held as early as September with the legislature to take another look at the forecasting with the Commonwealth's budget, that will have a significant impact, just not only for us, but other state agencies as well. And we'll be closely monitoring that, but we have already worked on that. Yes, sir.
Any of that able to be shared with the board at any particular time? And I fully understand if you can't, or the timing on that.
Yes, sir. We'll check into that and see about the flexibility on that. Yes, sir.
Yeah, I take it the first things that are going to be are unfortunately going to go, are things like dental care for adults and that are optional, or is it possible that we'll be able to keep some of that?
Well, I think for us, first and foremost, for the program itself, our goal is to maintain the program as it exists right now and make sure that we take proper care. Of course, we want to cover dental for sure. For adults, we're very excited about that. But I think the inclination will be, first and foremost, if it's been unallocated, it may remain that way, like a pause, until we can make sure other services and supports aren't removed or cut in the process. So.
And I guess one question that I know Patricia Cook had was testing for, especially for your FQHCs, testing for the uninsured is supposed to be covered by the feds. The manner in which they're doing it is incredibly cumbersome. There may be better ways, but better options there. But have you found that that your FQHCs have been able to get, or are going to be able to get, fairly quick payment for the uninsured for tests and for tests?
Sure, Michael. This is Ellen, and I will briefly say something, and then if Chethan is still on the line, I know he's been doing some work, and I just saw his name, so he is. He's been doing some work with the FQHCs here. On the on the testing payment front, I do know Cheryl Roberts and I kind of reached out to the FQHCs and asked whether they, to make sure that they were kind of signed up with the provider portal that allows them to access HRSA funds for testing and treatment for the uninsured. And just about, I think through 2 to 3 weeks ago, maybe a little more, they did confirm that all of their that their providers were getting enrolled, and that they, I don't know if it's 100% yet, but that they, were enrolled such that they could access those HRSA grant funds. Obviously, they can bill Medicaid for Medicaid patients, and Medicare for other payers, but for the uninsured, that bucket of money. Chethan, did you have anything to add on the FQHC front?
No, I mean, not too much. I think that's right. There's I believe it's a $1 billion fund, and I'm not sure if the feds are adding more to it or not, but it is, as you mentioned, specifically for testing and treatment for the uninsured. And so that's certainly one that the FQHCs are leveraging. I haven't heard problems as of yet with the operations of it, but I mean, it's certainly possible there are, but haven't specifically heard issues around the operations. That fund is also available for undocumented as well. So anyway, so that's one that the FQHCs are leveraging, and I believe CVS is also leveraging as well. There are a number of CVS testing sites. Last check, there were 39. I'm not sure if that's increasing or not, but 39 as of last check. And so also accepting uninsured and undocumented as well at no cost in terms of testing. But yeah, good question. But as of yet, haven't heard any issues.
Good, thanks. Anybody else have any further questions? Greg, you're going to have to unmute yourself. Greg, you're still muted.
Yeah, I think I'm unmuted now, Michael. Can you hear me?
Yes.
Appreciate it. Just real quickly, I wanted to thank Karen and her staff. We're a provider that works with almost all the state departments, and their flexibility and adaptability to move quickly and pivot has been appreciated. I know they've probably gotten some blowback from providers and others during this time, which I understand. But for us to be able to move quickly to telehealth and telework and get answers from DMAS has been extremely important. So I just, I don't know if the staff have heard this, but all the extra work they've taken on, and I was pretty impressed by the report today, because we're trying to move 450 employees forward, and I know how difficult it can be. But they've done a really nice job, and I appreciate it.
Yeah, I want to echo that as well. I'm sure everybody here does. It sounds like you guys have done just an absolutely extraordinary job under very tough circumstances. Especially, this is my own little you're operating under and partially under the Articles of Confederation, the way this thing has been managed at the federal level. So I think you guys have been just extraordinary.
Well, thank you all, and I
Any-
will take that back to Karen as well.
Please do.
If there's nothing else, can I have a motion to adjourn?
I'd so move. This is Greg.
Any seconds? Someone?
This is Maureen, I'll second.
Thank you. Folks, thank you very much. And look forward to the next meeting and obviously to hearing from any of you folks who have any suggestions for me. I'd be happy. I look forward to it. Thank you.
Thanks, everyone. And Michael, we're looking forward to working with you as chair here.
Thanks.
Thank you. And this ends today's session.